This conference will now be recorded.
Okay.
Yes, ma'am.
Good morning, students. So the topic for today is endometriosis. What do you mean by endometriosis? I think this topic is already done for you. Endometriosis is nothing but the presence of endometrial glands and stroma outside its normal location. Where it is located normally? Inside the uterus, endometrial cavity. So here it is located maybe within the wall of the uterus or peritoneal cavity, ovaries, abdomen, bowel, bladder, maybe previous scar. So outside its normal location, endometrium is located now, and it started functioning cyclically. So here the main complaint will be pain, dyspareunia, dysmenorrhea, progressive dysmenorrhea, and infertility and menstrual disorders. So it's very painful condition. By definition, this is the presence of endometrial tissue, both gland and stroma, outside the uterus. And the tissue is morphologically and functionally, when you take histopathology, you will see the endometrial glands and stroma. This is similar to endometrial tissue, and this responds to the hormones in cyclical manner. So outside the uterine cavity also we have a functioning endometrial tissue. So what are the theories? This Sampson theory is the most widely accepted and most popular theory. This is about menstrual regurgitation and implantation, metastatic theory, retrograde menstruation. So here the menstrual fluid along with the fragments and all endometrial fragments, they get transported back through the fallopian tubes into the peritoneal cavity. And wherever the viable cells implant, they start growing. So this is most commonly seen in young girls who have obstructive abnormality, some obstruction with the outlet of the genital tract. They have this retrograde fashion of this menstrual fluid along with the endometrial fragments. They get implanted wherever they fall, and they start growing into endometrial tissue. So this is most popular theory, Sampson's theory. See, in the diagram, normally the menstrual collection fluid along with the tissue fragments, everything will be shed off from the uterus to the cervix through the vagina outlet. So if any abnormality with the outlet, anatomical obstruction is there, they will start they go retrograde fashion through the ostia into the fallopian tubes, through femoral end into the peritoneum. So wherever it is implanted, if there is inflammatory reaction also, there will be endometriosis. The tissue will start growing. One more theory, ceromic metaplasia. The simple original ceromic membrane, now it transforms into endometrial tissue. This is metaplasia. And this type of this theory explains endometriosis in ectopic sites. And one more theory is metastasis through lymphatic and vascular theory. So the blood vessels and lymph, there is plenty of blood supply, plenty of lymphatic thing, extensive communication between all the genital organs of uterus, tubes, fallopian tubes, ovaries, pelvic, lymph nodes. So this theory explains metastasis through this circulation. And one more thing is genetic factors. The risk is 7 times more if first degree relative has endometriosis. If mother is having endometriosis, the daughter or if sister is having, they are more likely to be endometriotic now. So genetic takes more role, first degree relative. And one more is immunological factor. Reduced clearance of endometrial cells due to decreased natural cell activity or decreased macrophage activity. And one more is inflammation. Endometriosis may be associated with subclinical peritoneal inflammation. So these are the proposed theories. So what are the sites of endometriosis? Normal location is inside the endometrium. So outside locations, inside the uterine wall, in the myometrium, you call it as adenomyosis, or it can be present near the umbilicus or fallopian tubes, ovaries. It can be bowel, ileum, or bladder, vulva, vagina, perineum, pouch of Douglas, colon, intestinal tract, or can be on previous cesarean or some other abdominal scar. Scar endometriosis is also seen. So these are various sites of extra location of endometrium outside the uterus. So these are the types of endometriosis: pelvic and extra pelvic. Pelvic endometriosis can be, this is most common, peritoneal or ovarian or deep infiltrating endometriosis. And extra pelvic include genital tract, gastrointestinal tract, urinary tract, scar endometriosis, vaginal endometriosis, or very rarely can be thoracic endometriosis. These patients experience cyclical hemoptysis also. So clinically, how the patient presents to you. Classically, the triad will be of pain, dysmenorrhea during cycle. They will have severe dysmenorrhea, dyspareunia, pain during intercoitus, and deep-seated pelvic pain. Continuously, they will have deep pelvic pain, chronic pelvic pain. And this dysmenorrhea, it commences even before the onset of menstruation and continue throughout the cycle. And this is also of cyclical nature. So normally, when does this dysmenorrhea starts? On the day of cycle, which is physiological. But here this is pathological due to endometriosis, and they start pain even before the menstruation and continue throughout the cycle, and day by day the pain increases. You call it as progressive dysmenorrhea. And deep dyspareunia, pain during coitus due to stretching of the involved. If the uterosacral ligaments or some deep-seated pelvic tissues are involved, due to stretching of those tissues, they will have deep dyspareunia. And if the uterus is fixed, retroverted uterus, or involvement of uterosacral and rectovaginal septum, and dysuria if the bladder is involved, dyschezia if the bowel is involved. In case of, this is case of extragenital endometriosis. So they will have more severe pain. Abnormal bleeding. This may include premenstrual spotting, polymenorrhea, or menometrorrhagia. Menometrorrhagia means menorrhagia plus metrorrhagia. Intermenstrual bleeding and also heavy bleeding. So they can have these menstrual abnormalities also. And one more important, majority of the women present with infertility. So advanced disease, adhesions will be present, and there will be fixity resulting in structural damage to the two main organs which play a role in this fertilization, tubes and ovaries. So this impairs motility of the tubes and ovaries, thereby failed in motility of ova and sperm and fertilization. And also ovarian problems, if ovary is involved, it may lead to anovulation or luteinized unruptured follicle and oocyte maturation defects. If tube is affected, there will be altered motility. Tubal motility failed means there will be failure in ovum pickup and infertility. Peritoneal factors, there can be intraperitoneal inflammation. Sperm problems, there will be phagocytosis by the macrophages, and there will be inflammation and inactivation by antibodies. And endometrium, there can be luteal phase defect and implantation defects. So most of the younger population with endometriosis present with infertility. So what are the other symptoms? If there is extra pelvic endometriosis, they will have cyclically with every cycle, this endometrium will start acting like the endometrium which is present in the uterus. So cyclically, with when she is in menstruation, they will have rectal bleeding and hematuria in the urine or stools. And scar endometriosis, if the implants are there on the scar, they will have cyclical pain at the scar and also bleeding. Umbilicus, if it is present, it can present as an umbilical mass, and this also will have cyclical pain. If it is pulmonary, thoracic endometriosis, they will have cyclically hemoptysis and hemothorax. So these are the other symptoms in case of extra pelvic endometriosis. So what are the symptoms? Mostly pain, dysmenorrhea, dyspareunia, deep-seated pelvic pain, dysuria, dyschezia, hematuria, and infertility. So what are the signs? When you examine also, they will have deep tenderness. When you do PV, fornical tenderness will be, the patient will elicit pain like anything. So there will be tenderness in the cul-de-sac. You can feel the nodularity in cul-de-sac if the posterior uterosacral ligaments are involved. And fixed retroverted uterus if the adhesions are present. And adnexal tenderness, fornical tenderness. You can even feel these adnexal masses if the chocolate cyst or endometrial deposits are present in the adnexa. They will have masses. So to confirm this, we need investigations. What are the basic investigations? After all your basic clinical examination, parabdominal examination, speculum and PV examination, you did a PV and the patient is wincing of severe pain, she has cyclical pain, or she has menstrual abnormalities, or her main complaint is infertility. So you suspected of this endometriosis. So you have to confirm it now. The retroverted uterus with obliteration of cul-de-sac and bilateral complex adnexal masses are suggested. So bilateral adnexal means tube and ovary. If you have complex adnexal masses both sides, or if there is obliteration of the posterior cul-de-sac, then you will suspect this endometriosis. And you have to differentiate the endometrial cyst from other complex ovarian cysts like dermoid. Dermoid cysts are benign ovarian cysts. These are also complex like these endometrial cysts. So in endometrial cysts, the level of internal echoes with posterior acoustic enhancement will be seen. There will be some ground glass appearance like our endometriotic cyst. If it is a dermoid cyst, you all know there will be posterior acoustic shadow. You will feel like bone or tooth, opacities will be seen, hair will be seen in case of dermoid cyst, and the presence of mural nodule, pin and needle. So these are some ultrasound characteristics. So when you see the images, you can easily identify between these complex endometrioid cysts and dermoid cysts. So ultrasound is one of the helping investigation. And CA-125. CA-125 will be elevated in many conditions, like tuberculosis or any inflammatory process in the body, some malignancies like epithelial ovarian tumors. So all these conditions, CA-125 will be elevated. Likewise, here in endometriosis also, it is increased in moderate to severe cases. So also increased in non-mucinous like epithelial ovarian tumors. So when you suspect this, along with ultrasound, you can go for CA-125 levels also. If it is elevated, it is suggestive of your endometriosis. So to confirm it, always laparoscopy will be the gold standard, because we are clearly visualizing with our eyes whether these endometriotic spots are present or not in the peritoneum. So during laparoscopy, whenever you do laparoscopy for any case, you have to examine all the organs in the pelvis, entire pelvis, systematically in an order, in a clockwise fashion or anti-clockwise fashion. You have to see all the organs. So what are the aims now? You have to detect if there are any lesions of endometriosis present or not on any organ, bowel, bladder, peritoneum, ligaments. Okay. So if present, you have to take a biopsy from those lesions, because you have to go for histopathology and you have to confirm that it is endometriosis, and you have to go for staging the disease based on which organs are involved, and concomitant laparoscopic surgical treatment. If it is a simple chocolate cyst, you can remove excision of the cyst, or if these lesions, you can go for cautery or laser vaporization. So concomitant surgical treatment can also be done in case of endometriosis. So how these peritoneal lesions look? Classical lesions, they will look like gunshot lesions or powder burn lesions. They will be black, small nodular lesions consisting, because this is old hemorrhage, and this is surrounded by fibrosis and adhesions. And there will be scarring. There will be adhesions between the ovary, broad ligament, anywhere between the posterior uterus, vagina, sigmoid colon. So wherever the active lesions are there, there can be adhesions and there can be scarring. And typically you can see these powder burn or gunshot lesions, which are dark in color. Okay. If certain lesions, rarely you can see these red lesions, flame-like lesions with glandular thing, or white lesions, white opacities, yellow peritoneal patches, circular peritoneal defects, rarely you can see. But classically, we will see these powder burn lesions. If the ovary is involved, ovarian endometriosis, the endometrioma, you call it as chocolate cyst also, because the all old blood will be collected and form into an organized cyst. It will be chocolate in dark color, so we call it as chocolate cyst. The cyst contains thick, tarry, fluid, chocolate colored fluid derived from previously in previous cycles. With every cycle there will be hemorrhage, and it will be collected and organized into a cyst, and it can be adherent to the broad ligament or pelvic sidewall also. If it is superficial ovarian endometriosis, like in case of peritoneum, here also on the ovary superficial implants will be there, and here also there can be adhesions to the ovarian bed and subovarian adhesions. So these are the two types of ovarian endometriosis. These cysts are also mostly associated with infertility because the ovary is damaged now, problem with the ovulation, infertility. And deep infiltrating endometriosis, the lesions usually in the rectovaginal space, posteriorly, behind the uterus. May involve uterosacral ligaments, cervix, bowel, or uterus. And the lesions cause adhesions and scarring. You can see scarring and adhesions in the diagram. And it can be felt on PV also. When you do PV or PR, rectal examination, you can see tender. The patient will be having severe tenderness and you can appreciate this nodular mass. Okay, and our laparoscopy is always confirmative. And extrapelvic endometriosis, gastrointestinal tract, the frequently involved bowel are sigmoid, rectum, ileocecum, appendix. And the symptoms here will be again the pain abdomen and altered bowel functions. They will be disturbed and there will be cyclical rectal bleeding. And they may even have pain on defecation. Superficial implants may be seen on the serosa during laparoscopy. And urinary tract. If the bladder and urinary tract involved, common symptoms include again cyclical hematuria, dysuria, and frequency. So painful micturition. Pelvic ureter and bladder show implants in case of laparoscopy. If these implants are there, there can be again inflammatory reaction and adhesions, or because of scarring, there will be obstruction and hydroureteronephrosis. So this is if urinary tract is involved. Scar endometriosis. It can be seen at the umbilicus or port sites following laparoscopy. Already laparoscopy done. The port sites are also the sites for scar endometriosis. And abdominal incision, like for previous cesarean section or episiotomy, wherever the scar is there, these can be implanted. And they present as painful swelling, and it is more prominent that too cyclically during menstruation. But scar endometriosis, they usually complain of cyclical pain. Cyclical bleeding is very rare, but there are cases they show cyclical bleeding also. So cyclically at the site of scar, the patient will tell she's having pain. That is scar endometriosis. And vaginal endometriosis occurs in the posterior fornix as a continuation of endometriosis from the cul-de-sac. Thoracic endometriosis, lungs and thorax may be involved, leading to cyclically hemothorax and hemoptysis. So other confirmatory investigations are CT MRI, identical to the picture of ultrasonography. Color Doppler shows increased vascularity. Cystoscopy, if you suspect bladder is involved, you can go for cystoscopy and see inside wall of the bladder and confirm if any lesions are present. Next, sigmoidoscopy, if the patient have bowel symptoms, cyclically pain or bleeding, then you can go for endoscopy of bowel and see whether involved or not. Anti-endometrial antibodies. This is rare. Routinely, we don't do this investigation. In serum, peritoneal fluid and endometrial fluid, as well as in the normal endometrial tissue, you can see these anti-endometrial antibodies because inflammatory process is going on. And TNF, tumor necrosis factor, is obviously elevated in proportionate to the disease. If it is mild disease, mild, moderate. If it is severe disease, they will be elevated. And histology. Histology is always the confirmation. It is essential. On microscopy, typical endometrial implants with endometrial glands and stroma will be seen. So how will you classify this endometriosis? Stage 1, 2, 3, 4. Stage 1 include minimal, scoring 1 to 5. Small spots of endometriosis seen at the laparoscopy, but no clinical symptoms. For some other reason, for appendix or something, we did a laparoscopy and we have seen incidentally this small spot of endometriosis. Patient won't have any complaints. Clinically, no complaint. And stage 2 include mild. Score is 6 to 10. Here, there is scattered fresh superficial lesions, no scarring or retraction or any adhesions. Small superficial scattered lesions. And moderate is 16 to 40 score. They contain endometriomas less than, endometriomas means ovarian thing, less than 2 centimeter in size, and minimal peritubal and periovarian adhesion. Severe include score is more than 40, and here the cysts or endometriomas, chocolate cysts are more than 2 centimeter in size, dense peritubal or periovarian adhesions with restricted mobility. When you do PV, you can appreciate this mobility also, restricted mobility. Normal tissues will be freely mobile. And thickened uterosacral ligaments and involvement of bowel or bladder. All these come under severe type of endometriosis. So patient have pain, you did a PV, she has tenderness. So what will be your differential diagnosis? So always for this endometriosis, PID will be your first differential diagnosis. In PID also patient can have menstrual abnormalities, patient can have infertility, patient can have this deep pelvic pain, deep dyspareunia, similar tenderness on examination. So your first differential diagnosis will be PID. Chronic PID. In chronic PID, there will be formation of these masses also, ovarian masses. So next will be post-operative adhesions. Any post-operative case likely to have adhesions. How many times we open the abdomen, the more the adhesions. And old ectopic gestation can also form an organized mass. They also can have pharyngeal tenderness. Okay, and they can have pain also. Pelvic congestion syndrome also have severe pain. Irritable bowel syndrome, the one who is having this bowel involvement, they can have a differential diagnosis of IBS, irritable bowel syndrome, diverticulitis, ulcerative colitis, Crohn's. These are all the bowel conditions mimicking the same picture. So how will you manage? Now you confirmed after your laparoscopy and all your investigations. So how will you manage a case? So if it is asymptomatic and minimal endometriosis, you can just simply wait for 6 to 8 months, follow up. If she is a case of infertility, you have to start investigating further infertility. Otherwise, just follow up is enough. If the patient is symptomatic, you can go for drug treatment, minimal invasive surgery, and surgery proper. So drug treatment, we have many options. One is occipils, combined occipils. This endometriosis is estrogen dominant condition like fibroids, endometrial malignancy. The women who are prone for more estrogen, they are likely to develop endometriosis also. So we can give occipils for months to suppress this. Administered can be given intermittently or continuously. They have higher incidence of side effects and risk of thromboembolism. Occipils have these side effects because of the estrogen component. They are prone for thromboembolism in case if they are used prolonged. And seasonal occipils for 84 days for 3 months with 6 days tablet free. They also reduce the menstrual flow and also decrease the pain. Or you can go for progesterones. They exert an anti-estrogenic effect. Women who are already obese, having smoking, migraine, which are prone for thromboembolism, you can go for directly progesterones, avoiding estrogen. So they can be given continuous administration, and this causes deserialization and endometrial atrophy. So you can give norethistrone 0.5 to 20 mg daily or dydrogesterone 10 to 30 mg daily. So first option will be occipils. So when a woman you think are contraindicated for estrogen, you can go for only progesterone. This hormone does not prevent ovulation and it is suitable for a woman who wanted conception. Occipils prevent conception. So drug treatment, one more option is danazole. This is a synthetic derivative of ethinyl testosterone, mildly anabolic, anti-estrogenic and anti-progesterone. But here the disadvantage is it causes masculine effects, danazole. And the dose is 200 to 800 mg daily for 3 to 6 months, starting on day 1 of cycle. Side effect is weight gain, hirsutism, excessive sweating, muscle cramp, depression, atrophy of the breast and vaginal epithelium, or even virilism, deepening of voice also. Danazole, if used for longer duration, causes masculine side effects. And next option will be aromatase inhibitor, letrozole. This is given most of the times, 2.5 mg, or anastrozole 1 to 2 mg daily for 6 months. Anti-estrogen and prevent conversion of androgen to estrogen. So should be given with vitamin D and calcium to prevent osteoporosis. Women who are on these letrozole, they should be given vitamin C and D supplementations. So side effects will be nausea, vomiting, diarrhea. Next option will be gonadotropin releasing hormone. GnRH is administered continuously to downregulate and suppress the pituitary gonadotropins. This causes atrophy of this endometriotic tissue, and the synthetic analog GnRH is given in the doses of 10 to 20 mg IV twice a day. Prolonged over 6-month therapy causes hypoestrogenism and menopausal symptoms such as hot flushes, dry vagina, urethral syndrome, and osteoporosis. So you should be given under monitoring and cautiously. And next, RU486, that is nothing but mifepristone. This is tried at a dose of 50 mg daily for 3 months. This reduces the pain and also delays the recurrence. If the drug therapy is failed, so what can be the causes of failure of drug therapy? We change the drugs we have given but failed. Still she is having all the symptoms, pain, everything. So failure causes include the drug cannot penetrate the fibrotic capsule, or the ectopic endometrium responds less to hormones compared to normal endometrium. The endometrium which is present inside the uterus responds better and well to hormones compared to ectopically outside the uterus located endometrium. And side effects include all these drugs they prevent conception. If she is a case of infertility, she wanted conception now, but our drugs are preventing conception. Next will be minimal invasive surgery. What are the options? Aspiration of, if you see any peritoneal fluid in the cul-de-sac in your ultrasonography, you can go for aspiration. You can go for direct aspiration, or you can go for ultrasonography guided aspiration and see the implants are present or not. And next, destruction of the endometriotic implants less than 3 cm by diathermy, cautery, or vaporization by carbon dioxide or ND arc laser. Wherever the spots you see, you can go for destruction if the size is less than 3 centimeters. If the lesion is larger or chocolate cysts are there more than 5 centimeters, 6 centimeters, then you have to go for excision of the cyst by laparoscopy. Residual lesion can be dealt with hormonal therapy. Cautery of the cyst wall will be done in case of young female, and here again there is chance of destroying the ovarian tissue. Again, fertility problem. So minimal invasive surgery, what is the role of surgery? When we do, when the medical therapy is failed, when she is having infertility, when she is having recurrent disease, or if there is chocolate cyst ovary, then you have to go for surgery will be first. And laparoscopy breaking of the adhesions relieves from dysmenorrhea and pelvic pain. Next will be LUNA, laser ultrasound uterosacral nerve ablation. Nerve ablation for midline pain again decreases the pain. And prolapse of the genital tract and bladder dysfunction again noted with LUNAs. If you are going for nerve ablation surgeries, some cases this prolapse of genital and tract and bladder dysfunction is seen. So surgery, what are the indications of surgery? If the disease is advanced, if the lesion is very large and the medical therapy is failed, or the patient is not able to tolerate it, or after your medical therapy recurrence is there, or if she's elderly parous women, so we are not worried about infertility, then you can go for surgery. What is the aim? Coagulation of the peritoneal endometrial lesions. Adhesionolysis. If you find adhesions, you can release. If you find less than 3 cm lesions, you can go for coagulation of those lesions. And fenestration and drainage of the endometriomas less than 3 cm. If it is more than 3 cm chocolate cyst, you have to go for complete cystectomy. Next, laparotomy means not laparoscopy, open surgery. In case of advanced and very large lesions, if the medical therapy fails, and dissection and excision of the chocolate cyst, bigger chocolate cyst, or you want salpingo-oophorectomy, or elderly parous women going for abdominal hysterectomy and bilateral salpingo-oophorectomy, and premenopausal women may need HRT after radical surgery. HRT means hormone replacement therapy. HRT following bilateral ovarian removal. You remove all the ovaries in young women. The ovaries and the endometrium have functions, because too early hysterectomies, too early oophorectomies, they will have big deficit in the estrogen and progesterone hormones produced by these, and they will be facing menopausal symptoms too early if they are young women. So if you happen to remove these ovaries in case of younger women, for this reason, you have to go for hormone replacement therapy. Cyclically, we give the hormones to them prescribed, and this is under strict monitoring. And again, the risk of recurrence remains here also, because again we are giving the hormones. And total hysterectomy plus bilateral oophorectomy, women with severe symptoms and those fertility is not a problem, you can go for hysterectomy and removal of ovaries. Combined therapy. Sometimes preoperatively, even before the surgery, we will give for 3 months preoperatively GnRH. Why? Because this reduces the size and the extent of the lesions. and softens the adhesions, make subsequent surgery more easier and complete, because all these dense adhesions, fibrosis, it's a complicated surgery. So when we give this GnRH, it reduces the preoperatively, reduces the size, softens, and makes our surgery easy and also complete. If we attempt in a completely adhesions and a dense scarred tissue surgery, there is more chance of incomplete surgery. Some tissue will be left. So if you give this pre-operative GnRH, it helps make our surgery complete. And post-operatively also hormone therapy is given when the surgery is incomplete. If you feel after the surgery some tissue is left, some residual lesion is left behind, then you can again go for our post-operative hormonal therapy. And prophylaxis. Low dose OC pills reduce the menstrual flow and protect against endometriosis. 3 monthly OC pills are convenient and to take and also effective. Next, tubal patency test. When we do this tubal patency test, for infertility cases only, to test whether the tubes are patent or not. So better avoid these patency tests in immediate premenstrual to avoid spillage, because these tests again they do this retrograde spillage of the menstrual thing and more chance of endometriosis. So avoid these tests immediate premenstrual phase. And the operations on genital tract should be scheduled post-menstrual. During menstruation, just before menstruation, if you do some surgeries on the genital tract, again the more chance of this retrograde implantation and all. So after menstruation, if you plan these surgeries, lesser the chances of the patient developing endometriosis. Okay. I hope you understood. Wait, I'll confirm the attendance. Yeah, students, you can leave.